Hi everyone, I'm Jennifer Hahn. I'm a clinical pharmacist and the co-founder of Seeing Nutrition. And today I'm joined by our scientific advisor, Dr. Jocelyn Wittstein, orthopedic surgeon and sports medicine specialist. Her research has long focused on injuries pertaining disproportionately that affect women, including frozen shoulder, ACL tears in female athletes, and now a landmark framework known as the musculoskeletal syndrome of menopause. So that's why I'm particularly excited today to have this conversation with Dr. Wittstein because we're going to be discussing frozen shoulder and menopause hormone therapy and then tying all of that together to what exercises, what movements can we do if we have frozen shoulder. So, welcome, Dr. Wittstein.
Thanks. And I apologize for this lovely fluorescent lighting. I just literally finished seeing a whole day of patients and we're here. I'm just in the clinic still. So mhm.
You're practicing and busy, and so we always
Yeah.
appreciate you taking the
Mhm.
time to do these webinars with us.
Yeah.
Okay, so let's dive in and just start off by what is what is frozen shoulder? Can you explain what that is to us in plain language?
Yeah, sure. So frozen shoulder is a typically non-traumatic, like new onset shoulder pain that it can be really painful, like excruciating for some people, associated with sort of a progression to loss of range of motion. So stiffness that follows this acute inflammatory phase. And then there's a thawing phase. And this condition does affect women more than men. It also can affect people who have diabetes or thyroid conditions. And, it's something that for a long time was considered sort of idiopathic. We don't really know why people get this condition. Then it became, over the years, associated with some endocrine conditions, but still there was, this question of why is this sort of more disproportionately affecting women? And the key sort of point there is that this does mostly affect women between the age of 40 and 60, which is, of course, when women are in, perimenopause and menopause and postmenopause. And so there is definitely a greater likelihood of women being affected by this condition than men.
Mm-hmm. Yeah, that kind of segues perfectly into the question that I wanted to ask you was why has it been considered idiopathic and why do you think we're focusing more on it now? Is there a reason? And I think specifically if you could speak to the estrogen piece.
Yeah, I mean, I think that obviously one of the differences between men and women and in the 40 to 60-year-old age group is that hormonal transition.
Mm-hmm.
And we know that there are many effects on the musculoskeletal system with an estrogen decline. We also know there are many effects on the musculoskeletal system if you're someone who is, for instance, on medication that makes you not have estrogen, like an aromatase inhibitor if you have breast cancer, or if you have your ovaries removed and you have surgical menopause. All these states are low estrogen states, basically, where people can have increased joint pain, more rapid progression of bone loss, but also can have this greater, risk for frozen shoulder. And so, the shoulder is probably sensitive to estrogen in that there are estrogen receptors in the shoulder, but there's also some basic science. We know that like cells called fibroblasts, which can thicken and stiffen the lining of the shoulder joint, those can be inhibited by estrogen. So if when estrogen's not around, maybe they're more proliferative. That's one thought. But I think we've just like over time now learned or started to understand that frozen shoulder can be multifactorial. It may have an endocrine etiology, can have an inflammatory etiology, like maybe secondary to hormonal changes. It's probably not just one thing, but some of these things are connected, right? Like we know that use of hormone therapy can diminish risk of diabetes, for example, and improve insulin sensitivity. So maybe there's an endocrine, there's a connection there as well. There's probably a little bit of overlap. I do want to say if we go back in time to like the 1950s and 60s, not only was this sort of like considered idiopathic, it was also considered to be something that like certain personality types had. There was this concept of a frozen shoulder personality, which was basically like an anxious midlife woman, or you know, someone who was um neurotic and anxious, and to the point that that was actually studied eventually. Like people were like, we should study this. And then when it was studied in the 1970s, there was one study that actually supported that still, but in a more modern day study in like 2014, they disproved that. So even though it was like considered idiopathic, there was still this kind of like thought that there was maybe a certain personality type, for example, that was getting frozen shoulder. Now we've dispelled that now, but I think that that was probably just like women who were kind of in their late 40s, early 50s, maybe not getting any sleep and having hot flashes and night sweats and being exasperated by shoulder pain. But,
That
yeah.
would drive anyone mad.
Yeah.
But I think that also points to the fact that a lot of these things, like hot flashes or the anxiety that comes with menopause or the brain fog, has so long been dismissed. And that's what we see a lot of times in chronic pain, like in the area that I was practicing in, similarly to fibromyalgia. That's
Hmm.
also kind of a hard condition to diagnose when it comes to chronic pain.
It
It
is, and that's almost always in women. And so I think I don't always know if everyone who is told they have fibromyalgia actually has fibromyalgia. I'm not to doubt what someone is saying, but like, is it really just sort of more diffuse pain from, since this is I never see a patient, a man that has fibromyalgia. It's almost always entirely in women. So yeah, like there may be something that's going on with women's um pain
Mhm.
transmission and perception that is also affected by sex hormones. And there is some basic science behind that, that there is probably some central modulation
Yeah.
of pain through estrogen and progesterone that has been studied.
Yeah, it's so fascinating because we're learning more and more now that estrogen doesn't just impact, our female sex organs or things like that. Estrogen is present throughout our whole entire body and can have a lot of different effects, right? So we see that estrogen has an effect and may be related to frozen shoulder. We know that estrogen has effect with bone loss and thus osteoporosis. So
Mhm.
in this review that was published in the Journal of Clinical Medicine, they proposed this paradigm shift in thinking that frozen shoulder was a localized mechanical condition to now it's a systemic wide, body wide immunometabolic disorder, right?
Or
So,
yeah, the joint is responding to like a more of a systemic condition. Now, why is the shoulder more prone to that than others? I don't think we totally understand that. Or is there something about the shoulder joint, like the density of the receptors and things like that? Or, is it just the way we use our shoulders that there might be some minor trauma? Like I don't know, but the shoulder does kind of uniquely present like this in different ways than other joints with this sort of extreme pain and loss of motion and then thawing phase. It's very, I mean, you can understand why it was mysterious for some time. There are still some
yeah,
mysteries about it. Yeah.
yeah. And is it, I guess, related to that? Is it like usually just one shoulder because it's called frozen shoulder, or can it affect both?
Yeah, so in most people, it's just so this is actually hard to determine. Like, even when people ask me, like, how frequently or what percentage of people get frozen shoulder, everyone quotes this one old paper from you know, the somewhere in England where it was like they surveyed a bunch of people and asked them if they had had a bunch of problems, and 10% of the people in the population said they had had frozen shoulder. It's like that's so you hear this number, oh, 10% of women get frozen shoulder, but it all it's from this like one study. We don't really know the denominator very well.
Mm,
Uh like we don't know how many people actually get this, I would say. I think we underestimate the percentage of people that get it. And so if we're underestimating the percentage of people get it, we don't know exactly how many people get on the other side. There are studies that quote like a 15% chance of getting it, on the other side. But I think the actual percentage of women that get this condition is probably underestimated, especially if you're looking at that like age range.
right.
Yeah.
Yeah. is it possible to have frozen shoulder once on one side and then for that to go through the stages that you talked about and then develop it on the other side?
Yeah, so you could have it on one side and then get on the other. I have some patients that this doesn't happen as often, but where like years later they could get it again on the same side. That happens, I think, less often than having it on the other side. But the interesting thing is when someone has it on one side, they tend to recognize it much earlier and come in sooner and get it treated faster and get over it faster because they're kind of like, oh, I know what this is.
Yeah.
Yeah.
Yeah. Yeah, that's so interesting that it affects the shoulders disproportionately, maybe than other joints in the body. But exciting news is that your team ran a cross-sectional survey of nearly, I think it was 11,000 menopausal women and found
Hmm.
hormone therapy users had roughly an eightfold lower rate of frozen shoulder. And most women developed it and later started hormone therapy felt better. So,
Right. And this is, a survey study. It's not the highest level of evidence, but it is a lot of women who responded and like it's a lot of data. And you could have bias. You could have, maybe the people who are not hormone therapy users who are responding to the survey are people who are like really desperately like, you know, online looking for answers about joint pain. There could be some sort of response bias, but yeah, overall the association was that there was like a lower association of frozen shoulder in the hormone therapy users than in the non-hormone therapy users. And when we say people who started hormone therapy after having frozen shoulder, like more than half of them said that their shoulder symptoms got better, we can't necessarily attribute all of that to starting hormone therapy because there's time. The sun also rose that day. There's physical therapy they may have been doing. They might have had an injection. So it could be, improvement could also be multifactorial, but I do think this helps add to the picture and our understanding of this. And one of the things we continue to do is try to study people prospectively, and so we're still I still work with our women's health department here with Ann Ford, my colleague in Duke Women's Health, to study women prospectively. That takes longer, of course, and we would never gather over 10,000 women to have that information. So,
yeah. Yeah, I think it helps because we're learning more about frozen shoulder, which we already talked about was kind of this gray area that was just presumed to be almost like spontaneous in women, but we're finding that there's actual
it
biology.
feels spontaneous to people, yeah, because it can come on all of a sudden, yeah.
Yeah, but we're learning more. So definitely with a cross-sectional study, we can't draw causation, but it's
Mm.
still interesting to see the trends that you found. In the surveys that you found, did you see any differences in the incidence of frozen shoulder depending on the type of hormone therapy that they were on?
Yeah, so in this survey, we just asked them if they are using, like we list types, but or we don't have doses, just the type of hormone therapy that they were using had to include systemic estradiol.
Okay, yeah,
So
and
it's
that could be
systemic therapy. Yeah. But we
if
didn't like this is not at the granular level of like different doses or forms, a patch or gel or oral or ephemering, whatever, it's not at that level. We don't have that much granular detail.
so we know that if they were on hormone therapy, it was some form of systemic estradiol.
Exactly. Yeah.
Um, so where would you say hormone therapy fits in the treatment of frozen shoulder, and could it be considered an option to prevent frozen shoulder?
Well, so we don't have a prospective study where we like randomize people to using hormone therapy or not and then see if it prevents it. What I would say is that there are a good number of women who present with this condition while also having, vasomotor symptoms and perimenopause and menopause. And also, of course, sleep disruption, all these things could be interacting.
Hmm.
And so I think the trickier thing would be considering hormone therapy if you have frozen shoulder and let's say you're late perimenopause or menopausal, but you're not having all those other symptoms, there's still, of course, bone health benefits, reducing the rate of bone loss and improving bone density through the use of hormone therapy. So there's that piece. There might be multiple reasons someone might consider using hormone therapy. So I don't think we don't have the data to say that like you should use hormone therapy just to not get frozen shoulder, or you should use hormone therapy if you get frozen shoulder and you want to help it go away or not get on the other side. We don't have that proof. But what I would say is it's good to take an inventory of all the things that are going on. Like, do you have frozen shoulder, and are you having poor sleep, and do you have hot flash and night sweats? Do you have family history of osteoporosis? Do you have low bone density? And I think that you may then have some like lesser joint pain with utilization of hormone therapy. So it's certainly not like the indication for it. And that's what we need to continue to collect data prospectively on. I struggle with the concept of like even designing a randomized controlled trial where we would randomize people to hormone therapy or not, just to see if it affects their risk of getting frozen shoulder, because we also know that there are bone health benefits. And is that actually like equipoise? And like I guess you could say it would be equipoise for frozen shoulder, but maybe not for like, but what about these other aspects? Because hormone therapy does affect a lot of things. So I've more gone the route of trying to enroll people in a registry and follow them in a prospective way and better understand how these things interact. So that's kind of where I'm at on that right now.
Yeah, yeah, thank you for that.
Mm.
Uh, I think it also highlights the fact that yeah, hormone therapy isn't FDA indicated for this at all. It is
No,
indicated for
or
the
even for joint pain. And
yeah.
like upwards of 70% of menopausal women have joint pain.
Hmm.
And while many women do experience reduction of joint pain with the use of hormone therapy, it's not one of the indications. It's not like one of the standalone reasons that are approved, for example. So,
Yeah,
yeah,
hormone therapy is approved, FDA approved for the prevention of osteoporosis. So
correct.
if someone was on it, then maybe they could get some benefit and decreased risk of developing frozen shoulder, but it would be, I guess, like a byproduct of being on it for osteoporosis.
Yeah.
Yeah. Okay. Okay. What early signs or movement patterns should a woman pay attention to that might signal a frozen shoulder is starting?
So the first range of motion that I'm going to detect as someone doing like an exam on you, if you have really frozen shoulder, is the first range of motion that people lose is rotation at the side. So like external rotation.
Mm-hmm.
So if you were kind of like looking at side to side, how far out to the side you can rotate your shoulders, or how far in your peripheral vision are your hands, that tends to diminish earlier. And so people will have pain. I'm going to bend my screen down a little bit, like
Yeah.
at the end range. Like it might not rotate all the way out and it may hurt. Like it just hits a point where like, ouch, that hurts. We call that end range pain.
Okay.
That's one of the earliest signs, but that's not actually one of the first signs that people will notice, because that's not super functional for people. They're not like looking at how far they can rotate their arms out to the side. The range of motion that someone might notice first in themselves is the difficulty reaching behind the back. For a man, that's going to be doing a belt loop or tucking a shirt in or getting a wallet out of their back pocket. For a woman, it's going to be more trying to fasten a bra. Or the other thing women will notice is difficulty like shaving under the opposite armpit or washing under this armpit. Those, they might be a little farther along in the loss of range of motion if they're like, if that's what they're noticing. But those are things that are signs of frozen shoulder. Then the range of motion for overhead, like how high up could I push your arm overhead? If that's diminished, that's another range of motion that could be lost. But people tend to lose that rotation
Mm,
earlier. So, it would kind of present like kind of a lot of pain in the shoulder, pain when you try to rotate it away from your body. You didn't really have a major injury that you can think of. It then sort of progresses to feeling stiff. Ideally, if you start to notice the loss of range of motion, I
hmm.
would try to be seen by either an orthopedic surgeon or a primary care sports medicine provider, someone who's facile and comfortable with providing a steroid injection into the joint if needed. Just because once you start to lose motion, if you get many months into the losing of motion, it can just get really stiff and then it kind of drags out the whole thing. It just takes a longer time to thaw, the stiffer you get, the longer it takes for the shoulder to thaw out.
Hmm.
Uh, yeah, so that's kind of how you might assess yourself, I guess. Yeah.
Yeah. That's helpful to think about those things. Like, I'm just thinking, like, if I'm in my 40s and I'm starting to have other
Hmm.
symptoms like hot flashes or brain fog or whatever it may be, and then I'm having these issues with rotating, then maybe that's a early.
Yeah. And then what people also start to do is like stop doing other things because their shoulder is hurting so much. I mean, first of all, there's this other phenomenon where like women are taking care of other people, they're whatever, teenage kids doing stuff at the house, and they just like they delay their own appointments.
Yeah.
And so sometimes by the time I see someone, they're really stiff, and I so stiff that I don't know. I say to them, "Where have you been? Like, how have you been living like this?" And they're like, "Oh, I just haven't had time to take care of myself." Or they've just, I'm like, this is really abnormal. Did you think that this was normal for you to be living this way? Like so stiff, like you can't even reach your head. And they're like, no, I know this is bad. I should have come in sooner. So there's like the delay of taking care of yourself just because you're probably taking care of other people. And then there's also this like because you can't lift things or do things. I mean, I just saw someone today who's really struggling with frozen shoulder, having a lot of pain, not able to sleep. But then also she's like, I'm losing so much muscle mass because I can't, like, she's like, how do I lift weights when I can't carry anything in my arm? She's, not doing that stuff either. And so, sometimes there's a period of time where you have to work around that because you don't want to not be doing the other things that you need to do, for your bone health, for instance, because for your endocrine health, your for your brain health, and all the things that we like, all the benefits of strength training, for instance. So, but I see that too, where people just, women are just delaying or putting themselves in the back burner in multiple ways when they have frozen shoulder.
Yeah, that's probably a whole nother webinar.
Yes, it is. Yeah.
Not
My
only
point
is
is
like,
go see someone sooner rather than later. That was a long-winded answer for that. Yeah.
yeah, I mean, not only have we been putting ourselves last, but also I think another facet to that is like it's hard to get appointments, especially with
Mm.
specialists in a timely manner. So maybe that
Yeah.
melds
That,
together.
yeah, that can be an issue too. Yeah. If you're calling to or whatever, or trying to make an appointment, it's probably not going to be right away anyway. So, yeah, I would
Yeah,
just err on the side of being seen sooner if possible.
yeah. How long is each phase of frozen shoulder? So we have like the freezing stage, the frozen
Hmm.
stage, and then the thawing stage. How long is each stage?
Depends on the person. I mean, sometimes there's like a very quick progression to being very stiff. Some people have like a little bit of it's variable, I will say. We know that people who have diabetes have a much longer thawing process, for instance. Like it can take 2 or 3 years for the range of motion to return to normal, where someone who doesn't have diabetes might be more like 1 to 2. But you can see where it's like you'd like to avoid bottoming out in this like really limited range of motion so that what you're kind of thawing from is hopefully not super restricted.
Hmm. Would it be accurate to say that like if you got seen sooner and you were doing movements sooner, like in the freezing or frozen stage, then the thawing stage can be shortened, or is that kind of irrespective?
Yeah, like because you don't have to thaw so much.
Um,
Be like yeah, like you wouldn't be coming from so far behind, so to speak. Yeah. Hmm.
so being proactive about it is definitely helpful for frozen shoulder, which is
Right.
why early detection and early care is
Hmm.
important. So, just tying this into bone health a little bit, we know that like estrogen has a link to now frozen shoulder and osteoporosis, among other things. And the other link between the two is movement.
Hmm.
So, what are there certain exercises that women can be doing if they've entered that freezing stage
Yeah,
to
yeah,
prevent?
so like if you're frozen and you have like limited motion, so what happens is you can kind of get out of that inflammatory state, and after a while, people get into this frozen state where like it doesn't actually hurt so much, but it's stiff, and so it's like okay, you're not gonna, someone who has frozen shoulder is not gonna be able to do like an overhead
Yeah.
press, for example, because they don't have that range of motion, but they may have trouble holding, barbells to do a back squat, for example. You may be safer doing, like a Smith machine or something, or there are like some like hack squat machines, for example, where it's like sort of resting on your shoulders and you're still pushing the weight, but you're not having to like use your arms to hold it. Depending on how you're doing, you might be able to do like a farmer's carry, because with the farmer's carry, you're going to have your arms like more at your side. So that's not gonna, like, you're still carrying the weight, you're loading your spine and your hips, but you're not having to hold the weights in some kind of, extreme position. You may be able to do like a hex bar squat or deadlifting, for example. Now, some of these things would be like, you're not going to be able to carry something really heavy when it's all inflamed and painful. You may need
Hmm.
to do more like isolated lower extremity strengthening, which is doesn't have all the benefits of carrying weight. So it's like actually getting loaded through your spine and hips, but it's still better than nothing, right? Like if you're going to go do some of the lower extremity strength training equipment machines at the gym, for example. So,
Hmm. Yeah, that's helpful to hear that there's definitely modifications that you can do if you have frozen shoulder, but still do
mhm.
resistance and strength training that's beneficial for bones. Like don't not do anything because that's not going to help.
Right. And you might not be able to run because sometimes that hurts people too, the movement. But maybe you can walk, or maybe you can do like a stepper, or it's good to find ways that you can still be active. I mean, like when your shoulders is hurting a lot, you might just not want to do much, but maybe you can even go and do like some of the machines that you can adjust with the peg at the gym, like the
Yeah.
plates. So I think there are options to kind of keep moving and active. But yeah, like a common thing I see is people are just like, I'm just so inactive because I can't do this or that, and that's kind of
Hmm.
something to try to avoid.
I guess on the flip side of that, are there certain movements or exercises that women should avoid if they have frozen shoulder?
Yeah, I think when you're in that inflammatory early phase, it is you want to keep it moving, but you don't want to force it into painful positions. So you don't want to like be like, I'm just going to grit through this and force it to some spot it doesn't want to be in. Then it tends to get worse. So you want to keep it moving in whatever range of motion you can that doesn't hurt, and not, you don't want to put yourself into that sort of no pain, no gain mindset. You actually want to avoid extreme pain. Like it could feel like a little stretch, but you don't want it to be like inducing pain.
Yeah.
So that's where we were talking about earlier. Like, some people are able to do like, oh, I can do like some biceps or triceps work, but I can't rotate it really far away. I can't do an overhead press, and, things like that. They're modifying to avoid the painful end range of motion.
Hmm. And then, of course, it's important to see exercise professionals like physical therapists who have training and who can help you modify your exercises if you do have frozen shoulder. Is there anyone else that you think it would be helpful for someone to engage with in the interdisciplinary team if you have frozen shoulder?
Yeah, I mean, it depends on like what else you have going on. If you're someone who has endocrine conditions like a thyroid condition or diabetes, you want those to be optimized. Again, if you've got that overlap of vasomotor symptoms, or, the concern about bone health, and you're having this, working with your women's health provider, or it can be your primary care provider. Many people's primary care providers do, menopausal hormone therapy. And then, I think there are people who can't use hormone therapy. There's people in this situation where they're on, like I said, an aromatase inhibitor. That those patients, I just like to, I think that patient population is going to be at risk, and hormone therapy is probably not an option is not an option for them at that time. So that's somewhere I say like, definitely go get seen sooner, because you are at risk. So.
Yeah. Yeah, and I think bringing in the nutrition piece is also super important. Like
Mhm.
you get seen or referred to a dietitian who can help talk about anti-inflammatory foods because we know that
Mhm.
inflammation plays an impact in frozen shoulder and osteoporosis, really.
And optimizing your hemoglobin A1C. Mhm. Yeah.
Yeah,
Yeah.
all of that plays together. That's so fascinating that, frozen shoulder is thought of this as this one localized thing, but it's happening
Mm,
because of estrogen that's all over
mm,
the
mm.
body. Estrogen
I
is
think,
important.
yeah. Yeah. Yeah.
Well, I mean, I think that we kind of covered all of the basics when it comes to frozen
Mm.
shoulder, the movements, how to detect it early, who to see if you start having those symptoms. So I want to open it up to the people who are listening in on this call. You can either put your questions in the chat, or if you feel comfortable, you could go off mic and ask any questions that you have. So I'm going to just scroll through. Someone asked, is hormone therapy used for dual purpose, for joint pain as well as osteoporosis? If I were to ask my doctor for hormone therapy 6 years post complete menopause for osteoporosis, would it also help my severe knee pain?
So that really depends on, your what is the cause of your knee. So if you have like severe osteoarthritis of your knee, for example, I don't know what your knee x-ray looks like, that might not be helpful. If you're having like generalized joint pain, you may see some benefit. But yeah, like as we mentioned earlier, like joint pain is not one of the main indications for hormone therapy, although many women do have reduced joint pain when they use hormone therapy. But preventing osteoporosis is definitely one of the indications.
Right. Yeah. And I think we didn't mention it today, but there's also evidence to show that osteoarthritis disproportionately affects women, similar to
Yes.
frozen shoulder.
Yeah. Yeah, there is like definitely in, women over the age of 50 a greater risk of developing osteoarthritis than men experience. And some evidence that, for example, in knees, like women's cartilage gets thinner faster, at a faster rate over the age of 50. And some understanding that there are, estrogen receptors in the lining of our joints, like we talked about in the shoulder, also in the knee, that have this anti-inflammatory effect that sort of suppresses or diminishes some of the pathways that lead to cartilage breakdown.
Mhm.
So yeah, there's probably some hormonal influence that is creating this difference in men and women over the age of 50 in terms of the rates of arthritis.
Yeah. Yeah, another question that we got asked is, when does any sort of manipulation come into the treatment plan? I know we talked about like steroid injections, but when do you escalate toward?
Yeah, so a small proportion of people don't get better with non-surgical treatment. They stay, it's almost like how stiff are you and how dysfunctional is it for you? So
Mm,
someone could be maybe partway through this process where they have a really stiff shoulder, it's not painful, but the range of motion that they currently have is just very dysfunctional for them. And in order to give them better function, we might do a lysis of adhesions. That's a little arthroscopic procedure where we release scar tissue and manipulate the shoulder. Another reason someone might consider that would be like if they've just been at this for a long time, like over a year, and they're like frustrated with the timeline and they want to like
yeah.
get the function back sooner, you could do that. One caveat, it is best to avoid doing surgery for a frozen shoulder if you're in that painful inflammatory state because it can almost make it a little worse. It can kind of exacerbate the pain and the inflammation, and then you can get some prolonged stiffness. So
Mm,
ideally, if you're going to do a lysis of adhesions or manipulation, you would be doing that at a point where the shoulder is stiff but not super painful, which is there's a fine line. Yeah.
yeah, yeah, that's good to note that there's like, I'm just envisioning, the three stages, freezing,
Yeah.
then thawed. So like maybe manipulations are something that you consider if it's past the freezing and inflammatory state.
Yeah. Yeah. Mhm.
Okay.
It's a good way of looking
Someone
at it.
asked, you mentioned thyroids. Does the type
Mhm.
of thyroid condition matter? Hyper versus hypothyroidism? And I'm
Yeah, it could be either, but I think we see this more with hypothyroidism anecdotally. Mhm.
mhm, yeah. Um, Okay, well, I think that's all the questions that we have. Is there anything else that you'd like to touch on that we didn't talk about, Dr. Wittstein?
No, I think yeah, I think we've covered it. I think, the main takeaway is if you kind of think you have this condition, just kind of see a member of a healthcare team early. It could be physical therapy, it could be orthopedic surgeon, it could be, primary care sports medicine doctor who could help you. If a woman is not currently on hormone therapy and has very minimal menopausal, would you recommend it for its benefits? So, I think one of the major benefits of hormone therapy is preventing osteoporosis. The tricky part is, and this is like kind of where we are in this day and age, is that like the benefits of bone protection do go away when you stop hormone therapy. And so then you can get back into that like more steady loss of bone density. And I think the real question nowadays, which I don't have the answer to, I'm not like the person prescribing all these, and I think we're kind of heading towards this more and more, is just like why do we or when do we like you see people just randomly being taken off their hormone therapy at age 60,
Mhm.
it's probably something that should be reassessed over time. And if you remain low risk, like if you haven't developed breast cancer, which again has not been associated with systemic estradiol therapy, but like why discontinue that if remaining on that is what gives you the ongoing protective effect in terms of maintaining and building bone density and fracture risk reduction? Because there can be actually, when you stop hormone therapy, a transient increase in fracture risk. Actually, it doesn't stay elevated like that, but it's that is an issue. So I think, traditionally hormone therapy is thought of as being for vasomotor symptoms. And oh, yes, by the way, it also protects bone and helps you reduce your fracture risk, helps improve and maintain your bone density. But it's the only medication we have that is preventative of uh, osteoporosis. All of our other medications are treatment for osteoporosis. So that's another way to look at it.
Mhm.
What is the
So,
difference
couple of
between
questions.
What is the difference between tendinitis and frozen shoulder? So tendinitis is not going to restrict range of motion of the shoulder. And there are a couple different types of tendinitis. You could just have you've overused your shoulder. There's also something called calcific tendinitis that women can get, where you get little calcium deposits in your tendon. That is actually a poorly understood process. It's not from eating too much calcium. It's not, we don't really know why people get calcific tendinitis, but that shows up on an x-ray.
Mm.
And, we always check an x-ray because that can actually be acutely painful without injury. So it's one of the things I want to like rule out when I'm trying to decide what people have going on. But it's not like, and then people always ask if I have calcific tendinitis, do I need to reduce my calcium intake? And you don't need to don't do that. But that can be treated with either like aspiration of the calcium deposit, or it actually goes away on its own. And in a lot of people, majority of people will like kind of gradually resorb and go away on its own, and then almost never need surgery. But
Mhm.
tendonitis doesn't really produce stiffness. You might have difficulty actively moving your arm, but if I were to then examine your arm, it wouldn't actually be stiff.
Mhm.
So what
And
treatment do you recommend to reduce inflammation? That is a massive question. But, there are multiple dietary aspects that can have an anti-inflammatory effect. Colorful fruits and vegetables, high fiber, omega-3 fatty acids, um, choosing lean proteins, certain spices, so the diet can have a big effect. Hormone therapy can diminish, systemic inflammation if that's an option for you. Getting good sleep, and every time I say that, I know anyone who knows me well is guffawing because I don't get I tend to be a short sleeper, but you know, um avoiding nicotine, things like that. So but yeah, there are a lot of things contributing to systemic inflammation. Maintaining, good blood glucose levels if you happen to have, pre-diabetes or diabetes, trying to keep your A1C in a good range. All those things can help reduce inflammation. So,
yeah, and I think if you're in that freezing stage with a lot of inflammation, NSAIDs in terms of chronic pain have a role to help decrease some inflammation?
Yes, medications too. Yeah, can. And you don't want to be on those forever though. They have side effects, yeah. So,
Yeah, use them sparingly, but they do have a place in therapy for that. The steroid injections that you mentioned earlier.
yeah, which we don't use a lot, but like for someone who has this acutely painful frozen shoulder, it can cure the problem, so it is a good use for them. Yeah.
Hmm. Hmm.
So,
All right. Well, I think that's it. But yeah, thank you so much, Dr. Wittstein. I feel like we got a crash course on frozen shoulder. I feel like
yeah.
good understanding of what the different stages are and how we can detect it. I feel more prepared if I were to experience those symptoms. So thank you for the research that you've been
Oh, so
also.
you could just call me, Jenny.
If I ever need something, I have someone. But yeah, thank you so much. And then if you have any questions, if you're on the call, please feel free to just email us or let us know. And then we will share this video, this full webinar on our YouTube channel. Thank you for joining, everyone.
Okay, thanks. Bye.
Bye.